Hi, everybody. It's Kevin and it's Donna, and welcome to another episode of the Med List. And funny enough, we talked about the Med List and multiple things with our off-air kind of conversation. And I just couldn't be more excited, Donna. Like, this is one thing that just really invigorates you and I when it comes to transitions of care. And you might think it's weird because it's done so poorly and there's so many holes in it and so many issues that you're thinking. I've described it this way, Donna. It is a third world experience to be able to go from all of this care, all of these individuals, and then just dropping you off and hoping you have some level of success, for our patients. And I think it's that stark contrast that really draws my eyes to it so quickly as a clinician wanting to help in that kind of space. How about yourself, Donna?
Yeah, well, I've always learned and know that transitions of care, of course, is that kind of risky time where things could go well or they might go awry. And what do you do in order to not end up being readmitted into the hospital? So I think we're going to have some great conversations tonight on that and how to not be readmitted, but be successful in transitions.
Awesome. I love it. Let's get it going. All right, let's get our guest on stage.
Yeah. So hello, and we are so happy to have with us Dr. Amanda Mixon. So thank you so much, Amanda, for joining us. So just to let people know a little bit about you, and I'm going to let you explain a little bit more, but Dr. Amanda Mixon is a hospitalist and an associate professor of medicine in the Division of General Internal Medicine and Public Health within the Department of Medicine at Vanderbilt University Medical Center. She's co-director of the Center for Clinical Quality and Implementation Research at Vanderbilt and Deputy Associate Director of Research of the Geriatric Research Education and Clinical Center at the VA Tennessee Valley Healthcare System. There's just two other quick little points I want to say about Dr. Mixon, and this is, I think, so notable that she has invitations including serving as an expert for the World Health Organization Global Patient Safety Challenge, Medications Without Harm. And she leads the Pilot and Exploratory Studies Core for the U.S. Deprescribing Research Network. And it's the only National Institute of Health funded network of its kind in the U.S. So thank you for your work. Thank you for being with us. And I'm just so excited to learn so much from you today.
Thanks for this invitation. I'm excited too.
Yeah, great. Thank you. So, and I would love you to have you tell us more about you and your road to medicine and your research roles too. How did all that come about?
Okay. Well, it was a circuitous route, to be honest. So I went to college and I thought I wanted to be a doctor, but I got a little sidetracked. I went into basic science for a while, and then I really had this reckoning of like, I really want to talk to people about their health. And so I actually worked in public health for a while for the state health department in my state. And then I started thinking, okay, I want to get into medicine. And so went to med school. I did residency in internal medicine. And at that point, I got involved in quality. And I had done quality work in public health. And I didn't know that you could do quality work in medicine as well. And so my focus really has been so much since doing a fellowship in quality and safety through the VA around safety, quality, improving transitions of care and sort of quality of care in general. And I am a practicing hospitalist, so I only see patients in the hospital. Really during my fellowship got interested in how do we improve our healthcare systems. And so that led me into sort of this research space. And I've been in research for now, this is my 15th year on faculty at Vanderbilt and at the VA. And just really love being able to try to, see a problem and try to fix it, particularly as people are transitioning across settings of care.
Yeah. So thank you for sharing all of that with us. And I love people's journeys, right? Because they learn so much along the way to get them to where they are. And I love when all those pieces come together, and then we get to have you as a guest on the med list. So, but what I'm curious about too, and just so that everyone understands that, what exactly are the transitions of care, and why is this, like, the quality so important, and what might or possibly goes awry that is something that you might have researched or have had to think about a little bit further in correcting?
Yeah. So, we talk about a lot of transitions. There's from home to hospital. That's one big transition. And then from hospital back to home, perhaps. But for a lot of our older adults, that come into the hospital, they don't always go straight home. So they may go home with home health care, which is another transition. They may go home or from the hospital to a skilled nursing facility for short-term rehabilitation. And so I've really been interested in multiple settings of care because each of them carries their own risk. But I've really honed in on the medications part of this. Initially doing a lot of work in quality improvement around medication reconciliation at all of those stages of transitions of care, and then have gotten more interested in deprescribing. But really all of this has to do with trying to keep people, if they've come into the hospital, trying to reduce readmissions. It's a very complicated problem. None of us have, cracked the nut or found, the real panacea for all readmissions. But we do know that our older adults, particularly those with Medicare, they have a higher rate of readmission, whether they go home or they go to skilled nursing facilities. And so trying to get at how many of those are preventable readmissions and how many of them are not. And if they are preventable, are any of them related to medications or otherwise?
Yeah. And just to touch a little bit more on, some of those high hitters, if you will, and what research I think has shown is there are some key disease states and some key medicines even that might bring somebody back to a hospital versus others. So I know where I am and doing recommendations at the hospital, it's the COPD and heart failure and falls that are really big hitters for people coming back for readmissions.
Mm-hmm.
And I'm assuming, that we know that these are high averages in general across the country, but is there something else that you were maybe surprised you, or are you kind of honing in on certain disease states, or do you look at, kind of a wide spectrum and say, what happened in general and why did this person come back?
Yeah, we look at all comers usually. I did notice that there was a paper recently about older adults getting major surgery, and basically found that, people are coming back often with things that are not related to the surgery. That has been demonstrated before. So we really look at all kinds of causes. I think that even for surgical patients, usually it's a medicine related not surgical, I should say, reason of why they're coming back. And like you say, there are some conditions that just carry a greater morbidity. So heart failure, of course, is like one of the top readmission reasons. COPD, myocardial infarction, diabetes, all of those are really I would say conditions that put you at risk for readmission. And then when I think about medications, certainly things like high risk medications that have either narrow therapeutic indices or, they have high risk of side effects. I think that, those are the kinds of things that when we're thinking about talking to patients and even our handovers to the next provider of care, we really should focus in on some of those, both high comorbid conditions, but also the high risk medications.
What amongst those, Amanda, what trends do you see that kind of connect all of them together? I heard a clinician the other day use the word monosynaptic thought process, meaning really simple, one thought and you're there. And when we talk about heart failure, COPD, diabetes, complex medication regimens, we're not talking monosynaptic. We're talking about polysynaptic, multiple disciplines, multiple specialties. And so from my purview, it's been just a high level of complexity, right? And a high likelihood that error is going to result in harm. But
Yes.
what other factors have you really tied in to be able to concrete, this is the reason why failure ends up happening with these particular patients?
Yeah, I think so. It's not just medications, obviously. We have developed a model that was really trying to put domains around what are the ideal transitions of care. So things like, making sure people have advanced care planning. So certainly for our older adults, if they haven't sort of expressed their desires of what they want to happen when their disease progresses, I think that's super important. Obviously, connection to access. So making sure people have a follow-up appointment before they leave the hospital. Making sure their medications are correct. That's sort of my main interest. Educating patients on self-management, which I think, even for people who have low health literacy, you still can educate them in a health literacy sensitive way around their comorbid conditions and managing their medications. I think making sure that everybody's on board with diagnostic things that are still pending at discharge, and what is the monitoring that needs to happen for patients who have these high-risk conditions. I know one thing that's really become a big focus for hospitals is understanding social factors that drive health, right? And how did those play into patients' abilities to follow up, to self-manage? And so trying to connect them with resources in their communities, I think, is important as well. And then, just that continuity of communication across care transitions. So making sure that the information is in the documents that we give to patients, but also to the providers ahead of us.
Super helpful.
Amanda, when you mentioned the education of self-managing certain comorbidities, certain disease states, I know that we will often use action plans that are provided for COPD and also for heart failure, for example. And I think that they do an excellent job. And even teaching healthcare providers, the students, the residents, et cetera, as to, points that we might want to be making for the patients to make certain that they're staying in a green zone, let's stay at home zone versus a red zone back in the hospital. So I know that those are a couple of things I use. What do you highlight, any particular ones in particular that you particularly like and that you would recommend?
Yeah, so we have really tried to use a couple of strategies, particularly some of our research has been with how do you improve self-management in patients with low health literacy, or using at least a universal precautions approach to people, right? So assuming that they have low health literacy. So we have made medication listed discharge that are like pictograms. So instead of, using words, can we use symbols? So that people are understanding, when and how to take their medications. I think the prospective guidance, particularly for if patients are going to facilities, telling the next provider of care, here are the things we want you to be aware of, that you need to know about the titration of the insulin or the diuretics or what have you. I think for patients also, I love teach back and show back. So, talking about patients who are on inhalers, I find so many of them don't know how to use them. And our pharmacists that I work with in the hospital, they are wonderful in teaching patients how to use their inhaler properly. Because you'd be surprised if you don't ask people how they use it. A lot of them don't actually know, and they've been using it for years incorrectly. So I think some of those things that we can do that really don't take a lot of time, particularly teach back, like you're starting on a high risk medication. I want to tell you about how to take it, and then really getting their verification that they understand and closing that loop of communication with the patient.
That's great.
Like that. I think with the action plans and some of the additional education being provided by, not only stewards of medication kind of specialization with pharmacists, but also you mentioned some of the community health worker type of situations. We're talking about resources and other people to be able to help out.
Mm-hmm.
It really points me, Amanda, to something that, we're seeing a pretty big uptick in. I know that you and I both mentioned policy and some things that are happening around the healthcare space, that we've seen transitional care management, or TCM, remote patient monitoring, remote therapeutic monitoring, chronic care management, all pop up, as having some fee-for-service models that are now there for us to follow patients post-discharge.
Yeah.
What are you seeing in that space? There's been a couple interesting papers of late talking about what works and what doesn't work, but I'd love to get your take on how we're doing when we're transitioning patients home and applying that monitoring.
Yeah. I think it's super important. I think one thing that I've done a little bit of work in home health and around medications. And I think, what's the vantage point that people who are going home or providers that are going into the home have is that they get to see the patient in their environment and really get to see what patients are taking as far as medications. I think that the models of care where we can leverage, whether it's community health workers, like you mentioned, or nurses or pharmacists going into the home, I think just gives that really the clearest picture of what patients are being challenged with around self-management or medications, taking their medications, keeping them, transportation, all those things. Our hospital has a hospital at home program, which is another sort of model of care, right? Trying to get people into their home sooner. And from other programs around the country that do hospital at home, I think that model of care has really grown and has shown to really cut costs and also have really good outcomes for patients. So I think, and that leverages this telemonitoring a lot, that you mentioned. So I think the more that we can utilize both the technology, but also our workforce in an efficient way, hopefully is going to help. I think, policy is very hard. I'm a researcher, and it's hard for me to make that jump to being able to enact policy. But I think certainly payers are going to be interested in how do we keep people out of the hospital, because that's the most costly. How do we keep them out of skilled nursing facilities? That's also a cost. So how do we keep people in their homes and safe and have better outcomes as well for the patients?
Yeah, it's interesting you mentioned some of those pieces of the different settings, home versus skilled nursing, and then back to hospital readmissions and how costly it is, because the study that I looked at particularly said that if you do not have medication management as part of your transitions of care program, this was particularly looking at remote patient monitoring, the success rates were much lower, so significantly lower that they did not feel like the ROI was really there to continue doing those types of programs. When it comes to that, Amanda, what types of epiphanies have you come upon over the years when it comes to medication management successes and failures with discharging patients for you over the years?
I think, the reason I got interested in care transitions actually happened when I was in training and I had discharged a patient from the hospital. I thought, oh my gosh, this is great. We're getting him home. We've got all his medications. He's going to get home health. And we gave him a new wheelchair to get around because physical therapy had evaluated him. And wouldn't you know, he got home and his wheelchair wouldn't fit in his front door. And I was like, all the things that we do in the hospital to try to get people ready, and we still failed, right? Yeah. Just at the door of him getting into his home. So I think, I do think that we do know from our studies in medication reconciliation that having a pharmacist do medication reconciliation at the point of discharge, at least, ideally on admission as well in the hospital, is the number one most positive effect on downstream avoidance of adverse drug events. So I'm a huge proponent of pharmacists in that role. And we even developed ROIs, so return on investments of, can you invest in having a pharmacist on your clinical team? So clinical pharmacists, ideally, who are talking to patients at the point of discharge and really educating them. And that really has reduced that risk of adverse events, particularly around medications after discharge. So that to me is one of the most powerful things. And, you know, you obviously want to get the medication right as they leave the hospital. But the other part of that is making sure we get it right on the front end, because we know that errors that happen on admission often are perpetuated through to discharge. Okay. And so some of the work that I've done in the past has been about having clinically trained pharmacy technicians to take medication histories on the front end, right? And really utilize all the people that we have in our pharmacy to do the legwork of getting the medication list right. And you know, that extends to deprescribing, because if you don't know what people are taking, you cannot deprescribe. So it really is like having a lot of people involved and really having them at the top of their game, right? The top of their license to do the skills that they were taught to do. I think engaging the patient and empowering them to really understand their medication list at the point of discharge, where you know, people are often not at their ideal state of understanding that medication list and all the intricacies of self-management. But then, you know, the reinforcement of that when they follow up in the outpatient setting, I think is super important as well.
Yeah, well said.
Amanda, you mentioned also like this whole deprescribing part in the hospital and then moving that through. And I do see issues with that. You're very accepting of deprescribing. You're, you know, working so much at deprescribing and doing research with it, etc. So I know you accept it wholeheartedly. But in general, if you had to, you know, quantify it, is how likely is deprescribing happening in the hospital setting? And do you what are some of those barriers, or how can it be improved? How can patients become more involved? Maybe any thoughts on the whole world of deprescribing in the hospital setting and having that move forward?
Yeah. So if I could talk about a couple of the studies that we've done. So my research group has done 2 large randomized controlled trials of a patient-centered deprescribing intervention that starts in the hospital. And we targeted patients who were 50 years of age and older, who had polypharmacy, so came in with at least 5 medications. And they were recommended to go to a skilled nursing facility for short-term rehab. And the reason we picked that population was because we knew they had high morbidity and mortality and a lot of polypharmacy, but also the opportunity to monitor them in that skilled nursing facility phase. So we had developed a patient-centered intervention where we really first talked to the patient in the hospital and said, hey, you know, what issues are you having with your medications in general? Are you having adherence issues? Are you having cost issues? How willing are you to think about the idea of reducing or stopping some of these medications? And we got their buy-in first. And we had done a full medication history prior to talking to them, with their help also getting their medication history, but really, you know, on a medication by medication level basis, getting their buy-in. And we had a nurse practitioner that was geriatrics trained and a pharmacist on our research team. And they were the ones talking to these patients and getting the buy-in. And they had a protocol that they followed, a lot of times looking for, you know, is there an indication for this medication? Simple things. Are there duplications of medications in the list? Where does the harm outweigh the benefit of this medication? Looking at Beer's criteria, start and stop criteria, all those explicit lists that we use for deprescribing and high-risk medications, and making a prioritized list for that patient to weigh in on. And once we got the patient's buy-in, which was about 60% of the time, they agreed to deprescribing. Then we went to the inpatient team as well as the original prescriber of the medication. So we tried to contact outpatient providers whoever owned, quote unquote, owned that medication, right? And we asked them, hey, the patient has agreed to this. Do you also agree to it? And that acceptance rate was almost 80%, 79%. So quite high, actually. The interesting part of our data collection was also why they said yes or no, both on the patient side and the provider side. And we have it on a per medication basis. And so, one of the things that actually surprised us was, the things that we recommended for deprescribing a lot of times were over-the-counter medications where there was really no data to support their efficacy, but also things, that are a little bit harder, maybe like PPI is very popular, but often there's no indication for, or, limited indications for. We focused, I will say these two studies did not focus on any one medication class. That's one of the things that really we were proud of, is that we looked holistically at the medication list and didn't target any one class. We, of course, tried to reduce things like benzodiazepines and pain medications, and all kinds of, anything that we thought was high risk. And interestingly, some of those over-the-counter medications people were really passionate about keeping, which surprised us. But I think there is this power in sometimes people veering away from prescription medications and finding, their solutions in over-the-counter things. So we really did get quite high agreement. Now, when it came to actually seeing the medications deprescribed, we did a pretty good job in getting them deprescribed as the patient was leaving the hospital and going to the skilled nursing facility. Interestingly, we followed them through that skilled nursing facility stay, and then we followed them another 90 days after they went home. And at all those touch points, we had a full medication history taken to understand, what's happening with the trajectories of these medicines. And at 90 days, almost 1 in 5 medications had been restarted. So even though we deprescribe and we try to tell people, this is the new medication list at all these transitions of care, there's still this tendency sometimes to restart things. Now, whether we don't know if that was due to resurgence of, symptoms, or there was a withdrawal event and it was restarted. But I can tell you that we did also follow safety outcomes. So we tracked everybody who came back to the emergency department and was rehospitalized. And there was no difference between the control arm who got regular care and our intervention as far as safety outcomes. So we really do, like many other studies before us, think it's safe. And now we're trying to think about how do we do this work in people going to home health. So having home health nurses really engaged in this process, but even patients going home, because we do think that it's probably safe enough to do that as well.
Absolutely.
Wow. The amount of complexity in that study is very impressive. I mean, just the number of factors and confounders you had to deal with is very commendable, Amanda and team. The one thing I am curious about, kind of to rewind a little bit on the study, is something that Donna was mentioning earlier when it comes to assembling that med list altogether.
Yeah.
I've had lots of conversations with colleagues on like, what is a med list, right? How do you get a med list, in general? And so when you were doing the work to really be able to dive into what is truly a patient's med list, previous conversations for us have always been the 3 Ps, Amanda, that I've taught to students kind of over the years, of patient, primary care provider, and pharmacy. Like, you get those 3 lists and you have a decent enough list to be able to start with. What other things do you want to plug in there? Because I've had some colleagues say, all I need is just their EHR. Just give me their primary care's EHR list and I can tell you their med list. And I usually always take a deep breath, come back and say that, unfortunately, that is very wrong. But give me your insights. Don't let me bias you.
So 100% agree with you. And 100% of the time, the electronic health record list is incorrect. 100%. There's at least one discrepancy on that list. So you should never hang your hat. Never hang your hat on that list. So yes, you have to ask the patient. So when we talk about getting a best possible medication history, which is a term coined by our Canadian colleagues, you have to talk to the patient and you have to have another source of information. So I love your 3 Ps. I'm going to use that in teaching my students too. The other things we sought out were if they had been at a facility, we got facility, medication administration records. We also looked in the CSMD, so for controlled substances, making sure. And yeah, we called pharmacies, and it turns out people use on average like 2 pharmacies. So it's not that just, the fill list of their one pharmacy is good enough. You're going to have to like call multiple pharmacies. So this takes a long time. It takes a lot of effort. And that's why, many times the easy default is obviously just using the list that's in the medical record. No. It doesn't tell you about adherence though, right? And so many times I was just working in the hospital last week. I asked a guy, how many times do you take your Robaxin? It's written for 4 times a day. And I was like, oh, this could be causing his falls, right? And he said, oh, no, I only take it twice a day. Well, if I didn't ask him that question, I wouldn't know, because it's not written anywhere in the medical record, right? And, the difference between a dispensing list and the medication list is also huge, right? Because
massive.
And a lot of, I think, physicians don't understand the difference between those things. It's like you can make a med list from anything, but what's actually dispensed, and then the step further is then what is actually people taking.
Yeah,
huge. And I think one fun anecdote. I think Donna, you might have heard this story, but I'll share it. I remember a pharmacist telling me he worked with his dad, and his dad was working at the pharmacy, and he was dispensing to a gentleman his first suppository. So most folks know that a suppository is usually given in a certain route that most people are not accustomed to. And so this pharmacist said, sir, do you need any help with understanding how to utilize that medication? And the gentleman said, oh, no, I'm fine. I've taken these, before. And the son was talking to his dad and said, Dad, what's different about taking that medication? As he was about to tell his son how he was supposed to take the medication, they saw the patient walk over to the drinking fountain, unpeel the foil wrapping, and swallow the suppository. And and there's a good example of just what you were pointing out, that patient interview of understanding not only what the dispensing record looks like, what are they buying via OTC or supplement records in general, but how are they taking it, and are they taking it is so huge, not only for the clinician, but one thing you emphasized before the show, Amanda, is for the patient to understand that. So when they're keeping that medication record, can you tell us a little bit more on what should they be keeping? What kind of information should a patient have on that record in particular, the one that they're taking to everybody?
Yeah. So I think that when they own their medication list, that's a really empowering thing for patients. And if they can keep it up to date, because that's the other thing. If you go to different health systems that don't talk to each other electronically, then, the cardiologist may not know what the primary care doctor has prescribed. So if the patient can keep that information up to date and accurate, and then I think the subtleties, like you mentioned, of like how I'm taking it, it's written this way, but maybe it's PRN and I only take it, twice out of 4 times that it's written. I have a colleague who his grandmother lives in India, and in India, people have a card that they keep with them. And that card is their medication list, electronically, like encoded. And they can just take it to any provider, and then that provider can read that card and see exactly, what the patient is at least prescribed, right? Yeah. And so I think it really is important for our patients to have that information in their hands. Mm-hmm. And if they have low health literacy, I think, again, it's an opportunity to engage their family members, caregivers. How can we work as a team to help the patient take the medications, appropriately, correctly?
Smart.
Sure. Amanda, I'd love to learn more about your work with the World Health Organization. I think it's really important that people know that readmissions and polypharmacy and all of these things that we talk about and the need for deprescribing is worldwide and not just a US issue. And as we spoke of, all these different international deprescribing networks too, and their challenges as well. And being able to share that information amongst the the world is pretty wonderful. So could you speak a little bit more on that, and just like how the World Health Organization is trying to help with this
Yeah.
whole, readmissions and polypharmacy and deprescribing altogether?
Yeah, so back, I think it was in 2017 that they started this, their third sort of patient safety challenge that was focused on medications. And they really wanted to develop, how do we do this worldwide, particularly in low and middle income countries and in, higher income countries, focusing on medication reconciliation. And what are the really like universal steps that we can all agree on? How are we going to operationalize that across different settings of care? And so I was part of this working group that came together and was really trying to knock out, like, what is it that we're saying when we say, you must take a medication history? How do you do that? And what does that mean? What are the steps of that? How do you do the reconciliation at discharge? Who should do it? How should you do it? How long does it take? All those kinds of things, and trying to codify some of those best practices, if you will. And then, I think, how do you implement those things? So one of my interests is in implementation science. So that's like, we can make all kinds of guidelines and, best practices and all these kinds of things. And that's great. We publish tons of data and information in the medical literature, but how do you actually get it into practice? And what are those barriers to getting them into practice? So we talked a lot about, how would governments, ministries of health, U.S. government, like, who do you engage in these conversations? Is it the government? Is it the insurers? Is it the patients? And I think it's all of those stakeholders and people who are engaged in the process of taking medications and giving medications and paying for medications, that you all have to have at the table. I think that there is a growing, I think particularly, since COVID, there's an interest and a focus on medications, and people are, I think, more aware of the damage that medications can cause. I mean, certainly the benefits, we prescribe them to help people, but there are the downsides and the dangers of medications. And, there are some grassroots groups that are trying to bring to light some of these issues. There's a group that the USD Prescribing Network is affiliated with, called Team Alice. That is a group at the University of Buffalo, and they've really highlighted in very poignant stories about people, this Alice person who died because of medications that were harmful. And so I think as we need more stories like that to come to the forefront and be in the consciousness of people to realize, like, I was talking with some friends about how these GLP-1s are so popular now, and everybody should take them, but surely there's some downsides. And I think that talking about, yes, there are always a benefit and there's always a risk to medications. And how can we talk about the risks in a way that patients understand? Because one of the things we've learned about deprescribing is that patients don't like that term, first of all. They feel like we're abandoning them in their care. And so how do we talk about optimizing your medicines? And even words like, reducing risk. How can we use different terms that mean the same thing, but are a little less scary, I think, for patients, so that they're more apt to agree? Like your sleeping pill, this was never intended, for long-term use, but how can we talk to you about this? And sometimes it's, how we phrase it. Maybe it's not reducing falls, but, taking less medications, the burden of the pill burden or whatever it might be. And I think so some of that is, the work of all of us in trying to figure out what are those messages that are going to resonate with people. And certainly it depends on the patient too.
Oh, that's a good point.
One thing I always love to say, which I started saying to folks, especially after the American Society of Consultant Pharmacists annual meeting where a group of us were talking, and I said, deprescribing is thought of as not treating, but it
Yeah.
truly is treating. We treat by deprescribing, because if you're having an issue or your patient's having an issue and it's because of a drug, you're deprescribing that as an actual treatment, and you can actually like code that. You can actually put an ICD-10 code or put it into how are you managing this particular issue that the patient is in the hospital for. Well, you're doing it by reducing, stopping, or switching a medication. So, and that's all deprescribing. So I love to think of deprescribing as a way to treat, and it doesn't mean not treating. It means we're treating in order to optimize your health and all these great things that we're talking about. And I think the other thing, and there's, we talk a lot about adherence too, right? And talking about if meds need to be adhered to. And Script Your Future is a challenge that's done each year by pharmacy schools and other disciplines that pharmacy schools match up with. And the whole point is to have people adhere to their medications and the importance of that. And their message is to, what's that value? Why would taking this medicine be important to you? What value are you finding in it? Because if we go to the store and we buy it, there's a value, right? So what value for you to go through the process every day of taking a medicine is there? And when we can put the value on, how do you feel, right? Or how do you value this medicine? And how can we help you value that you would maybe even feel better if you're not taking this because of those risks? So adding some value language, I think, is really important too.
Yeah, I love that. And value sometimes is in the eye of the beholder, right? So we have to kind of understand what's motivating the patient to take the medication too. But yeah, I think that would be super helpful if we have the language about value in there.
Yeah.
Speaking of value, we had a poll, a Medlist poll prior to starting the episode, and it was really just asking the question from a bunch of clinicians' perspectives, and those are everybody that answered the poll were clinicians in one way, shape, or form. But it was asking the question, biggest issues resulting in failed transitions of care. And there were 4 options, and the one that was chosen most frequently, 50% of the respondents said it was due to poor clinician communication. So of all the ones to really talk about, Amanda, I would love to get your thoughts there on, we're having great clinician communication here, talking about sharing ideas, doing the 3 Ps, getting all these, tidbits from Amanda's research. I think it's really positive, but in actual practice, I have to put my nerdy technology hat on every once in a while. Some struggles happen systematically because we don't have operational systems in place to be able to link data across different care settings, right? We're not able to just automatically, it might sound wild to the public to know this, but Amanda in her hospital can't send Donna in her hospital information by snapping her fingers. It just automatically doesn't happen. There's an entire process that kind of goes in place. We're getting more transparency. There's much more transparency data going out there and legislation to make that happen. But right now it's broken. What things have you seen, Amanda, when it comes to poor clinical communication on both the positive and negative side, on where we're kind of going there to make sure that at the very least, everybody can see the recipe that's going into the dish?
Yeah. Well, I think that we've known for a long time that discharge summaries are meh, at best, right? Like they're either too long or they're too short. They don't have the information people need. It's not in a structured way that's helpful. It's like, too much to read. I mean, I think that we can do a lot better. And one of my mentors had done a lot of sort of early research on what are the elements that are important in discharge summaries, how many of them are missing. So, I mean, you'd be shocked, like missing diagnoses, missing, medication lists. I mean, things that you think that are really sort of elemental parts of the discharge summary are missing. So I do think, what is it? I think we have to put in our mind as we're writing a discharge summary, who is this for? So is it for the provider? And if so, what does that provider really need to know to take care of this patient at the next step? So
Right.
that's where I love this idea of prospective guidance. Like, hey, we were tapering down their insulin because they came in with hypoglycemia to the hospital. This is where we're at now, but it probably needs to go down further. Can here's what our plan is for doing that.
Yeah.
I think I see a lot of like lab tests that are pending at discharge that never get followed up. So that's important too. The other thing that we worked on a lot with sending patients from hospital to skilled nursing facility is like functional things. So like, do they have a Foley? Can they walk around? I mean, just knowing some of that stuff, right? You have a better picture of who's coming to you, right? As the receiving provider. And so sometimes I think we need some of those really practical things in our discharge summaries, rather than just like this long prose about what happened in the hospital. I'm really cutting to the point of what does the next person need to know? And then I think, the other thing to sort of differentiate is that the discharge summary traditionally has been for the next providers of care. The discharge instructions, though, are for the patient, and they really need to be in patient-friendly language, with educational pieces, with a medication list that they can read and understand, not in SIG, scripts and tiny font and things like that. And so how do we make that paperwork useful for the patient? And again, telling them, I think how to do some of the self-management part, right? Like we're better about it now with heart failure. Like, okay, you gained 3 pounds in 3 days, you need to take an extra dose of your furosemide or whatever. But I think we could do better. And some of that is, how do we do that? Who is doing that? Again, I think the pharmacist is so critical at the point of discharge to do some of that teaching to the patients. Mm-hmm. Again, using simple language. So I'm a big proponent of using patient-friendly language that is, not technical jargon.
Uh-huh.
You came in because, when you use terms like heart failure, people get really, scared, right? My heart is failing. Well, it's not working as well as it should. And we gave you these medications, so trying to put it into the context, again, of the person who the list or the document is intended for, the audience.
It's funny because I think as healthcare providers, we often shy away from the word sales and marketing. Like it just gives us the heebie-jeebies. But we can't be good at our jobs if we're not good at sales, right? Yep. And in general, if we're not speaking to the audience that we're giving information to. And I think one interesting plug for me, especially in this big boom of ChatGPT and large language models, is really every high school student and Donna and Amanda both teach. I teach a few things on the side, and I'm sure every one of our students knows how to use an LLM to write the way that Donna wants it to be written, or the way Amanda would like to have something written when it comes to information. Why can't we use that exact same thought process and those exact same tools to write toward the clinicians that we're partnering with, or to the individual patients that we're trying to dictate information to? And the other piece that I love you call out is we don't always have to produce something, right? When we're looking at a discharge summary or discharge instructions with using one of these models, that then one of us has to go and review and then make sure everything's appropriate to then send off. Mm-hmm. The other piece is just finding out where are the holes, like where are the gaps when I am trying to transition from me to Amanda, from Donna to Amanda, et cetera. Mm-hmm. Where are the big gaps in what the communication pattern is, or where are the big questions that Amanda's going to have that's a tool of technology could look at it and say, what about these things? Do you have any information to fill these gaps in? So there's a plug-in on that side. But the last one I really had, Donna, really comes along these lines for Amanda. And it's when we're looking at some of the other things that were there on that list of options for biggest issues resulting in failed transitions of care, that poor clinician communication was there. Mm-hmm. Health record transparency we've talked about, but one that is one that did not receive a single vote, was lack of patient education, in general. And maybe it's because it wasn't lack of patient education and resources. But any thoughts there, Amanda, on how we can make our communities better to receive patients coming home?
Yeah. I do think there is a role for good patient education. And again, it has to be on their level. right? We can't be talking above our patients, and getting them engaged at the point of transition. So also engaging their caregiver, if that's appropriate, or a family member, because again, more people hearing it in a structured way, the better, probably. I think empowering the patient to take that information, that medication list, and keep it themselves, as I mentioned before, make sure they keep it up to date, and encourage them to ask the questions. So, one of the things I think that's come into the deprescribing world is like, we should be talking about this when we are prescribing the medication on the front end, right? And so, okay, so I just had a stent placed in my heart and you're telling me I need to take clopidogrel. Well, how long do I need to take that for, right? So that the patient then knows, this shouldn't be on my medication list for 10 years, right? I mean, so how can we engage the patient to also have that knowledge and understanding of their medication, so that when they go, again, to a provider that's maybe not in their same health system where they just got care, that they can relay some of that information and share it, if the electronics don't communicate. But the patient is the one thing that is constant across all these care transitions of, settings. So I think that if patients can get engaged and empowered to keep their medication list, that's one of my biggest sort of, if I had a campaign, that's what I would do, I think, nationwide.
Yeah. That's great. Amanda, thank you so much for being with us. And I just think we shared so many wonderful ideas. And like you talked about, just having that med list is so important for the patient to have it, right? And have it available. And it's funny, I was just talking to somebody just recently, and he cares for his mom and a couple of aunts, etc. He goes, I don't think I've ever seen any one of them have a med list. They have tons of meds. Don't get me wrong. They have tons of meds. I don't think I've ever seen a med list. And so something as simple as that, where, if you're talking with family members, I like to think about, like, here we are at our Thanksgiving program here, and what are we doing? We're around the table. Everyone's talking about their health problems, right? So let's talk about, do you have an updated med list, for one thing? Have you done your Medicare open enrollment if necessary? And then also, instead of like, what are you taking? What aren't you taking anymore? Like, what did you not need anymore? And start having those conversations. How are you feeling better by taking less, maybe, or taking something that's more appropriate? What happened that way? Versus, oh my gosh, I'm taking more meds type thing. What if you're taking less? I always say that to folks when I'm speaking with them at senior centers. I'll be like, just tell me how you'd feel if you weren't taking all the meds you were taking. And they're all like kind of smiling. I go, I see that smile, So there's something to be said about that. There's the value, right, that we talked about, is that'd be really nice not to have to worry about all of these things. So I appreciate all the value that you are putting into all of the research that you're doing, because it's so important to get everyone on board, prescribers and healthcare consumers alike. So I think that is just wonderful. I know that you had mentioned, like, the importance of the patients having their med list. What about providers? What's the one thing that you would, hope that you and your colleagues do in order to make certain that we're taking steps in the right way for transitions of care and
I mean, I think it's pretty simple. It's like, we get the history of why the patient has come in. In that history, just asking them about, how are you taking your medications? That's all. I just want to know about their adherence. I mean, I can see the medication list, but like 100% of the time, we said it's inaccurate in the list, right? Whether that's a paper list or electronic list. What's important, and the only thing to me that's important really, is how are they taking that medication list? What medications are they deciding? I mean, I had a guy, again, in the hospital said, I take my Lasix every day except for Sunday because I go to church. And I don't want to pee while I'm in church.
And I have a big ham dinner.
That was great for us to know, right? Like he wasn't there for a heart failure exacerbation, but that's not in a prescription, right?
Yeah.
And so
Yeah.
how they're taking it is the most important thing. And so, but you have to ask. That's the biggest thing. The provider has to ask.
Yeah, for sure. Thank you. Thank you so much for being with us. I want you to be, if ever I need to be in the hospital, which I hope I don't have to be, I want you to be my hospitalist that's taking care of me. It's amazing. And I just love that energy that you bring to the med list. So thank you for sharing that on the med list too. And Kevin.
Amen. Well, I appreciate you, Amanda, and your kind of outlook on how we've got to change some things in healthcare and the very realistic stance that you take when it comes to, you do some incredible research. You've put together a bunch of guidelines and things, but really your heart is, how do we make that impact human beings, right? How do we make it impact clinicians and patients so it makes a real difference in our communities? And, I hope that things like this, us putting out good, hopefully quality content to let people know they can be empowered by something as simple as a handwritten list, an application in their phone, something to be able to say, here are these chemicals that I'm putting in my body on a regular basis. What are they? How do I do it? And be able to get that to all the providers around them. So thank you for that, Amanda. Any parting words for the audience? Wanted to share anything on things they should check out or resources, ways they can get a hold of you or connect with you, all that good stuff?
Yeah, I mean, I'm happy to share my email address. I don't do a lot of social media, but the US Deep Prescribing Research Network, which was that deepprescribingresearch.org that you showed, is a great resource. You can join that network and we won't spam you, but it's information about deep prescribing. And there are resources for clinicians on there, and resources that link you to resources for patients. So I think the more we sort of socialize the idea of optimizing medications amongst providers and patients, hopefully, then we're having better shared decision-making when people come together.
Beautiful. Beautiful. Well, thank you so much for your time. Everybody that joined, thank you all for the poll responses. Thank you for all that information when it comes to data exchange and information that you plugged in there, as well as all your comments, likes, and love you've shown Donna and I over these last, year, Donna?
Yes,
this
yes.
is the year mark for us. So over all these episodes, appreciate you guys. Keep following and liking on YouTube, LinkedIn, Facebook, Spotify, Apple, and all those other fun locations you can find the med list. And until then, we will see you guys next time.